You hear a general practitioner talking to a patient named Sarah Glesson. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at your notes. Sarah Gleason, come in, please, have a seat.
Hi, doctor. Thank you.
So, what can I help you with today?
Well, I'm a little worried because of a couple things, actually. I've been taking a combined oral contraceptive pill called Monofem to help me, well, for more regular periods. They've been a little crazy the last few months, so the last GP prescribed it for me. The first few weeks I thought I noticed something, like I just felt different somehow, a little off, but I thought it was just my body getting used to it. But it hasn't been getting any better, so I want to check that out. And the second thing is, well, I'm worried I may be pregnant.
Okay, well, look, let's start with how you've been feeling and then we'll move on to that because it will be helpful to establish the symptoms first. Can you describe those for me?
Well, the first thing I noticed was these really bad headaches. They kind of spread out all over, but they always start around my right eye, and they just seem to last for hours. I'd take some paracetamol, but nothing would change. I tried drinking more water and just resting in bed. They just kind of stay there, and they're like nothing I've ever experienced before. On top of that, I often get really nauseous as well. I've never actually thrown up, I only get the sensation, kind of like motion sickness.
Okay. These symptoms are quite common actually. Is there anything else?
Well, I've definitely put on some weight. I think it's about 5 kilograms. I just feel really bloated, and I mean, that's a lot to put on in a short time. Until recently, I also noticed some spotting, and it definitely wasn't my period. It just started happening at the oddest and most inconvenient times. But now, well, it's stopped altogether.
Okay.
That's why I'm really worried, because the truth is I sometimes forget to take the pill. If I forget, I try to take the second one on the same day, like my last doctor told me to do. But, well, a couple weeks ago I forgot 3 days in a row, and then I started taking the sugar pills by mistake. I just got so confused. Obviously, my partner didn't know, so he didn't use a condom. Then once I remembered, I went to the pharmacy to get the morning after pill, but I think it might have been too late. I almost bought a pregnancy test at the same time, but I was feeling far too nervous then to even take it to the counter.
Okay, a blood test can confirm it, although this may take a couple of days to get the results. These days, a home pregnancy test is very accurate and you'll get the results far sooner, but confirmation is needed before making any changes to what you're taking now. Until then, I'd strongly advise using other forms of contraception.
Okay, but is it possible to have a urine test here in the clinic now? My friend had one of those, and I think I'd prefer it. Once I leave here, I might chicken out again, and I'd rather just know now.
Of course.
And also, I think regardless of the results, I should maybe go over all the information about the pill again with you, because I find it all a little confusing. If the result is negative, then I'd like to try again with a different brand and try to be a little more responsible with taking it. Maybe it would be a good idea to make a family appointment too, if you wouldn't mind. I think it would be good to bring my partner along so he can learn all about it too. And if the result is positive, well, it's a good chance to go through everything together.
I think that's a great idea on both accounts. I'll start by
You hear a general practitioner talking to a patient named Jane Brown. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at your notes.
Welcome, Miss Brown. May I call you Jane?
Yes, of course.
I understand you've just registered as a new patient with this practice.
Yes, I've just recently moved to the area and my old doctor's a little too far to travel.
No problem, and you've come here today because of some discomfort in your left arm, is that correct?
Yes, that's right. Well, it's actually a pain along the bone on the outside edge of my forearm. It's kind of more numb than anything and sort of spreads to my little finger. It started about 2 weeks ago, I think, and comes and goes, but there's definitely something wrong there. It's getting quite painful, especially at night. It's even caused me to wake up a few times. And sometimes if I stretch out my arm suddenly or if I bend it with any force, the pain, it's hard to describe, kind of like a guitar string being wound really tight.
Okay, and have you tried anything for it?
Well, I asked a few friends and they said it's probably a pinched nerve and to try just resting it on a pillow. So I did, but that didn't make a difference. So I looked it up online and it was recommended to put some ice on it and also a heat pack, alternating a warm compress with ice, kind of swap from one to the other and also see which one worked the best. It also said I can take anti-inflammatories, which I did for about a week, and it made very little difference. It also said I should do some gentle stretching exercises, but at the time they hurt to do, so I didn't really follow through with them.
Right, and you're 22. Are you working or studying?
I'm still at university. I'm doing a Bachelor of Science. It's my final year, so it's pretty hectic. I spend most of my days sitting at a computer.
Okay, can you tell me more about that? How long you'd spend at the computer, I mean?
Well, I'd sit there anywhere up to 10 hours or even more some days. It's pretty uncomfortable at home. We have a really large desk. It's one of those old antique things. My dad bought it at an auction. It's just that it's so high, so my forearms and I guess also my wrists have to lean against the edge of it when I type. Sometimes I sit there for a few hours and don't really move them very much. If I'm concentrating on my work, then I don't notice the kind of pressure I'm putting on them, but I often see that I have deep creases kind of halfway down my arms when I stand up, so I guess it might be quite a lot. Now that I'm saying this, it's pretty obvious that that might be the reason for the pain.
I'd certainly say it's a contributing factor. Is that the same at university?
Well, if it's a tutorial, then I sit the same way as at home because the tables there are terrible and I'm so used to it. If it's a lecture, we have those little flip-top tables, so I can sit properly with my back straight because there's nothing to lean against, and they're a comfortable height. I also have a question, if it's okay.
Yes, of course.
Would playing a lot of sport help this kind of injury or make it worse?
It would depend on the type and the intensity.
Well, I play netball on Tuesday nights, not for competition, just a mixed group of friends. I also swim twice a week, but about half a year ago, I joined the university rowing team. That's what makes me really feel it because of the action of my arms having to stretch and bend at the elbow so much. And that causes really intense pain. It's hard and you need to be fairly strong, but I enjoy it, so I want to keep at it if I can. That's another reason I'd really like to get this sorted out. I haven't played any sport for the last 7 days because of the pain, but I really want to get back to it. It's kind of addictive.
A break's a good idea. They sound rather rigorous. What I'd like to do now is examine not only your arm, but also your neck and
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B or C which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. You hear a nurse briefing a colleague at the end of her shift. Now read the question.
Okay, so the next thing is about Susie Williams in bed 3.
Right.
She's been admitted for chest pain to rule out MI. So far she had an EKG, which was okay, and the first set of cardiac enzymes and troponins are negative. When she came in, her blood pressure was elevated a little, like 182/95, but she was given losartan, and at 6 o'clock it was 142/82. She was also dehydrated, so we started her on IV fluids. D5, half normal saline, running at 125 millilitres. That can go until midnight and then it can be disconnected. She's scheduled for a stress test tomorrow and some more enzyme tests. Okay?
Okay. Question 26. You hear part of a hospital management meeting where a concern is being discussed. Now read the question.
Now I'll hand over to Jenny, who has a few words to say about staffing. Jenny?
Thanks. Now, if we compare ourselves to other hospitals of the same size in other regions, we're actually recording lower rates of staff turnover. That's just as well, given the challenges filling vacant positions across the sector. Where we do compare unfavorably is in the number of days lost to sick leave. That's making it hard to maintain full cover on the wards, and we all know the costs of that. As a matter of urgency, then, HR are looking into the worst affected areas to understand the reasons behind it and to see if there's anything we can do to help and support the staff involved.
Question 27. You hear a GP and his practice nurse discussing a vaccination program. Now read the question.
It's coming up to that time of year when we have to start preparing for the flu vaccination programme.
Yes, we usually do it at the start of next month, don't we?
That's right. If you remember last year, we hired a local hall and did as many people as we could in one afternoon.
Yes, I just started working here then. It was a hectic couple of hours, but it worked pretty well, don't you think?
Sure, but there's been so much publicity recently about how sensible it is to get the jab that I suspect we'll have a lot more people coming along this year.
So we better think about taking on an agency nurse, perhaps, to lend an extra hand.
OK, let's run that by the practice manager, and she might have some other suggestions too.
Question 28. You hear 2 hospital nurses discussing the assessment of a patient on their ward. Now read the question.
The bed manager just rang. He wants us to clear 3 spaces in the ward today.
Oh, it's never ending. Let's see what we can do. There's no one ready to be discharged, but we could try chasing referrals for Mr. Davison to the community hospital for rehab. Where are his notes?
Yes, but has he had his assessment yet?
They were all away at that conference yesterday and the day before. I think he'll have slipped through the net.
But Dr. Amat's already got him medically stable and signed off, so he should be the next one to move on.
Well, I'd get him there as quickly as possible before they give the place to somebody else.
I'll phone them straight away.
Question 29. You hear the beginning of a training session for dental students. Now read the question.
This is session number 4, which is going to include, again, impression taking. We've created the crown impression of tooth number 30. We also took care of an inlay preparation. So today, we're going to stay on that side with our impression taking. We're going to make a duplicate of what we've already done, and our attention to detail is now going up another notch. When I take an impression of a tooth that I've created in the mouth, I naturally have to take care of the saliva, the blood, the gum tissue. We're not going to cover all that today. You'll hit that next semester. What we are going to cover are the dynamics of your impression, the margins, the proximal contacts, the bite, and the occlusion. We're going to capture all that in one impression.
Question 30. You hear 2 nurses discussing the treatment of a patient with a kidney infection. Now read the question.
I can't see the results of Mr. Roberts' last blood test to check creatinine levels. Did you do the last one?
No, not me. Let's see. Here it is. The last test was 4 hours ago and results show a level of 38, so it's still well below normal. We'd better do one when he wakes up, as it might have changed. The patient's not keen on needles, though. I had a real job last night trying to convince him it was necessary. Not the easiest of patients, if you're happy to have a go.
Okay, my turn, I reckon.
Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best, according to what you hear. Complete your answers as you listen. Now look at extract 1.
You hear a specialist in medical ethics called Anna Capston giving a presentation on the issue of burnout in the medical profession.
Hi, I'm Anna Capston from the Division of Medical Ethics at University College. Today I want to discuss the quite urgent topic of burnout among medical professionals as it's becoming. It's kind of an epidemic, but I really think that we're not talking about this enough. That's why we're here today, to get a bit of information out there and start a conversation. So, what is it? Well, burnout is a psychological and behavioral syndrome. Emotional exhaustion is one quite common hallmark of burnout. It's been defined as long-term, unresolvable job stress, a sense of being overwhelmed and depersonalized and lacking a sense of personal accomplishment. A recent study from the Mayo Clinic showed that in 2011, 45.5% of doctors reported that they felt burned out, and that number has now risen to 54.4% in 2014. More than half of all doctors in this country are saying, "I really feel that some aspect of my work as a doctor is making me feel burned out." This is really trouble. It's trouble because a doctor who feels this way can commit more errors. They suffer from compassion fatigue or just not being able to empathize with others because they have their own emotional issues. They may retire early, therefore reducing the workforce. They may have problems managing their own lives. 400 doctors committed suicide last year, which is double the rate of the population average. There's trouble for patients in having a workforce that's burned out. There's trouble for doctors in terms of their own health and well-being. We don't talk about it much. We like to think that doctors can handle everything, but it's clearly not true. It's a problem, and there ought to be some solutions. One type of fix is to make sure that hospitals and other healthcare environments try to create better conditions for a happy workforce and for happier doctors. This might include yoga, mindfulness training, having more therapists to talk to, encouraging people to come forward when they feel this way, peer groups, and better mentoring. There are a lot of tactics that we could pursue and try to engage in. I'm not sure what's best, and maybe one size does not fit all, but it's time to really build a safety net so that we can keep our workforce functioning and we keep physicians at their careers and doing a good job, not making mistakes, not being indifferent to patients, and not harming themselves. This really is a problem, and we've got to attend to it in the workplace. It's just as important as any other aspect of workforce safety. When we institute new software, or when we have new bureaucratic regulations, I think somebody ought to ask, what does this do to the workforce? If one more doctor complains to me about Epic and other types of electronic record keeping and billing forms, it'll be one doctor too many. It takes a lot of energy, makes a lot of people unhappy. A lot of the software and computer assistance that's out there doesn't seem to help the doctor. It makes more work or makes them feel frustrated. It also seems to me that if you look at what's going on with respect to regulations and administrative or bureaucratic requirements, nobody is saying, hey, is this user-friendly? What's the burden that it's putting on the doctor? It's just done to save money or allow people to collect bills more reliably, but it's not asking what it's taking out of our workforce. I believe that morally, we've got to make sure that a highly trained workforce that takes a very long time to get the ability to practice medicine is a resource that we preserve and really take seriously. I don't think we're doing that as part of employee or workplace safety. I think it's crucial, but it's being ignored. We also have to view it as part of patient safety. And I think we should start spending some resources to figure out how we can make the physician workplace more user-friendly. How can we make it a happier place to be? What can we do to institute regulations, guidelines, software, and bureaucracy to try it out on the workforce for a while to make sure that they're satisfied and that it's not making their lives more miserable?
Now look at Extract 2. Questions 37 to 42. You hear the discussion of a physician with junior doctors on refractive error. You have 90 seconds to read questions 37 to 42.
Hello, doctor. What is refractive error and what are the types of refractive error?
Well, a refractive disorder is an ocular condition caused by changes in the eye shape that prevents light from being focused sharply on the retina, creating vague images. The causes may range from congenital shortening or lengthening of the eyeball through variations in the shape of the cornea to anomalies of the lens. During the process of refraction, the light bends when passing through the cornea and the lens. This helps direct light from the objects we view exactly on the macula, the part of the retina that has the maximum number of cone cells, which are the photoreceptors responsible for detailed and sharp vision. Myopia or short-sightedness happens when the eye refracts light so much that the rays converge to a spot in the front of the retina, leading to a blurred image when one looks at objects that are beyond a certain distance. However, objects that are close can be seen clearly, as the light rays are divergent at their origin, and so undergo the right amount of refraction. The eyeball in such people may be too long, or the cornea may be bulged more than usual, leading to the focusing of light before it reaches the retina. The condition is usually diagnosed in childhood, between 8 and 12 years. It stabilizes in the years between 20 and 40 in most cases. A family history of myopia may predispose to the condition. It is correctable using prescription eyeglasses, contact lenses, or refractive surgery such as keratoplasty. People with high myopia have a greater risk of future retinal detachment. Hypermotropia is also called long-sightedness, that occurs when light rays reflect too little and so focus beyond the retina, leading to poor vision for near objects. However, light from more distant objects is parallel, and so usually comes to a focus at the retina with this lower level of refraction. Some hyperopic people cannot see well regardless of the distance of the object. The eyeball may be shorter, or the cornea flatter than usual, or the lens may have less refractive power than is normal. Like myopia, eyeglasses, contact lenses, or surgery may be recommended for correction. Astigmatism is a condition in which the shape of the cornea is uneven. For example, it may be curved more in one direction than the other, or show areas where different curvatures. As a result, light rays are scattered and come to focus at different spots on the retina, rather than forming a single sharp image. This leads to blurry vision. Eyeglasses are usually recommended, but contact lenses to smooth the refractive surface and refractive surgery to chisel the cornea to a smooth contour may also work well. Presbyopia is a refractive error caused due to aging. As the lens inside the eye ages, it loses its power to change shape, with the pull of the ciliary muscles in response to the need for greater or less refractive capability. As a result, it becomes less able to accommodate itself, so as to focus light from nearby objects clearly. Near vision becomes a problem, leading to the characteristic picture of people over the age of 35 or 40 holding books farther away than usually in order to see them clearly. Eyeglasses are the best way to correct presbyopia. Bifocal glasses have two different refractive powers, with the lower part being designed for reading and the upper part designed for distant vision. This is the end of Part C. You now have 2 minutes to check your answers.